Good morning, everybody, and thanks to the organizing committee for inviting me to speak today. They've asked me to touch on the topic of endometriosis and infertility, and it's a very vast topic to discuss because there's so many variables to it, but I thought I'll touch on a few important points. So by the end of the talk, just if we can get a brief understanding of what endometriosis is about, a little bit on how and why we think it occurs, the diagnosis of it, the different staging methods and stages of the disease process, and if it does affect fertility at all, and if it does, how it affects it, and then just briefly on some treatment options that are available. So what is endometriosis? So this is a simple definition: the presence of endometrial tissue outside the normal uterine cavity. So there's different classifications. That's not too important for this topic, but if I can just explain to you in a very simplistic form that, So this is a schematic representation of the female anatomy. And I'm sure we all know that. That's the uterus, cervix, vagina, rectum, bladder, and the pelvis of a female. So the lining of the uterus is called the endometrium, and that's where it's supposed to be. And that's normally shed every month. And it contains blood, of course, endometrial glands and tissue. And if this pieces of tissue, endometrial glands and tissue, is found out of the uterus, let's say it's found in the ovary or the abdominal wall or in the rectum, then these pieces of tissue are known as endometriosis. Now, if we know that in a normal menstrual cycle, the pituitary gland controls the ovary to produce follicles. The follicles then produce hormones called estrogen and progesterone. And of course, under those hormones, the endometrial cavity becomes responsive and receptive to a potential embryo. Now, the same way that the endometrium, that is the lining of the uterus, is responsive to the hormones that the ovary secretes, the pieces of endometrial tissue outside the endometrial cavity will respond the same way. So it also grows, becomes dilated, and when menstrual cycle occurs, then these pieces of tissue also would bleed. And that's the problem. The problem is that as these pieces of tissue bleed, they invoke an inflammatory response, it causes adhesions, and then causes this condition called endometriosis. Now, I've been asked the question many times, why does it occur and how does it occur? In actual fact, I won't be able to answer that correctly because we all don't really know. First of all, there's only theories behind how it occurs, and I can't explain as to why somebody would get it and others wouldn't. So the theory is behind how this occurs because it's difficult to comprehend. How is this endometrial tissue outside its normal position? So the first and probably the most plausible theory is one we call retrograde menstruation theory, or the Simpsons theory. As I mentioned before, the endometrium, that's the lining of the uterus, is under control of the ovary. And every month, if there's no pregnancy, menstruation will occur. And the menstrual blood that flows out through the cervix into the vagina and the outside will contain endometrial glands and stroma. But it may also flow backwards. So now it normally flows outside, but it can flow backward, and this blood can flow through the fallopian tubes and then enters the abdominal cavity, then gets stuck to all different parts of the tissue, and that's how is one of the major reasons why endometriosis occurs. And this explains most of the endometriosis occurring, but certain endometriosis will occur in sites other than just in the pelvic region. So there's two other theories, and I'll just go very, very quickly through them. I think it's not important for this lecture, but just to understand that the second theory is that the peritoneum, which is the lining of the abdomen, comes from the same cell line or coelomic epithelium is the endometrium. And if it undergoes a metaplastic change, instead of growing into peritoneal tissue, it will grow into endometrial tissue and then become under the influence of the ovary and bleed. So that's the coelomic metaplasia theory. And then we've also found endometriosis in all different sites, like the liver, like the skin, the umbilicus, the lungs, the pleura. And that doesn't explain the retrograde menstrual theory. So there's also a thought that it perhaps acts almost like a cancer, doesn't kill you, but it acts like a cancer and can disseminate to different parts of the body just by simply entering the bloodstream or the lymphatic system. So those are the theories behind how endometriosis occurs. I found this nice caption, and it says that my lining is strong and independent. It grows everywhere. Okay, so that's the crux of the meaning of endometriosis. And this uterus is very cool, and it says, isn't it that cool? But in fact, it's not that cool. It causes quite a bit of problems. So what are the symptoms of this condition called endometriosis? The problem is endometriosis doesn't follow any distinct pattern. So some people will have this symptom and others will have another symptom, and there's varying degrees of how they would present. But however, the most common symptom is pelvic pain. And this is a typical example of patients coming to see us complaining of pain. The description of the pain is quite horrific. It's unbearable. It's almost like labor. It's agony. It's hell. And often patients are so distraught that even despite taking lots of medication, they just regret having their menstrual cycle. So the most common symptom is pain. Some people take medication and they may even resort to a very stiff drink every month. So it's quite sore. Pain occurs in different ways in endometriosis. It all depends on where the endometriosis is situated. The most common type of pain will be premenstrual and during menstruation. So typically a patient will tell you, you know what, just before the menstruation starts, I get this pain, it's unbearable, it lasts through the whole of menstruation, and as soon as menstruation settles down, the pain starts improving. And that's a more typical example of endometriosis type of pains. But if endometriosis occurs in the area behind the uterus, then it tends to occur with intercourse. We call it forgot the term. So a typical complaint would be at the time of intercourse, the patient will have quite severe pain. However, they may present a lot with chronic pelvic pain as well. Okay, throughout the month, they have this non-specific pain, it's a nagging pain, and it just gets worse at the time of the period. One also may have pain during urination, just around the menstrual cycle, low back pain, or pain on passing stools. And this is called dyschezia. So I just remember now, pain is called dyspareunia, and this is called dyschezia. It's not important, it's just pain during those periods of time. The second most common symptom apart from pain is infertility. Patients often complain that they're having difficulty in falling pregnant and have pain. How often do we find this condition in the general population? In fact, it's very, very common. It is thought that almost 1 out of every 10 women suffer from endometriosis. The estimated amount, and this varies from different studies, is that probably in the world about 176 million women have endometriosis. And this is usually during the prime of their lives, during their reproductive age. The unfortunate thing is most of them have not been diagnosed or treated. The prevalence is about 5 to 10% of women in the reproductive age group. About 25% of infertile women will have endometriosis, and 50% will be complaining of chronic pelvic pain. The longer the disease goes undiagnosed, the more damage it can do. The problem is that diagnosis is often very difficult. And the reason for it is that you start having pain at a young age and you think it's normal. And you go to your mum and say, you know, I've got this pain, and they go to a doctor and they get some pain medication, and you sort of become accustomed to it and get used to it. And you think it's just normal, and you just get by, and it's being ignored, and in fact, the person has endometriosis. The other problem is you can have different degrees of endometriosis, and it will respond to a different type of pain. Some women will have a very mild form of endometriosis and have excruciating pain, and others will have a very severe form of endometriosis and have more minimal type of pain. The third problem is that the pain, as I've mentioned, you know, you get pain with intercourse, pain passing stools, pain passing urine, mimics other medical conditions such as pelvic inflammatory diseases, irritable bowel syndrome, urinary tract infections, and they often go misdiagnosed. It takes apparently an average of about 4 years for a woman from her first symptom till she starts discussing the problem. And probably an average of about 9 years before she starts from the time that she experiences these symptoms from actually being diagnosed. So you can see there's a huge delay between the time of symptoms and the diagnosis. So how can we diagnose endometriosis? Of course, one would need a pelvic ultrasound. But a pelvic ultrasound is normal in many, many patients with endometriosis. It's only the ones that are very severe and they have these large cysts, then you can suspect endometriosis. Other modalities of investigative tools have been tried, such as MRI and CT scan, and once again is helpful in more severe diseases, but not helpful to the average patient. Other things that have been tried are biochemical markers. It's known that a marker called CA125 is found to be raised in people that suffer from endometriosis. The problem is it's also raised in other conditions like infections, fibroids, and cysts. So it's not a definitive marker and not a very good marker. The only definitive way to diagnose endometriosis is via a procedure called laparoscopy. So the laparoscopy is considered the gold standard in diagnosis of endometriosis. What is a laparoscope? A laparoscope is an operative procedure. It's done under anesthetic and under a guidance of introducing a very, very small camera, about 5 millimeters, half a centimeter through the belly button, we'd be able to visualize the entire pelvis. And on visualizing the pelvis, we'll be able to see all these different features of endometriosis, and that would be the only definitive way of making a diagnosis. The problem is, it's an invasive technique, it's done under anesthetic, and there are risks involved with all types of surgery. The advantage, however, is that let's say we suspect endometriosis and don't find it, so it's an exclusion. At least you can tell the patient that, look, we've looked for endometriosis, it's clear, then we've got to look for other causes for pain. But it also assesses the rest of the pelvis for any other conditions, such as cancers, ovarian cysts, infections that may be present. The other advantage of undergoing a laparoscopy is that if you do find that the patient has endometriosis, it can be treated at the same time. What I thought I'd put up is what we look at when we do a laparoscope, and then you'll be able to appreciate the different types of presentations of endometriosis, and we'll be able to see how we go about diagnosing it. That there is a perfect example of a normal pelvis. So it's important that you see that's what's normal so you can appreciate what's abnormal. So this is a normal pelvis, a normal uterus, a normal fallopian tube, normal ovary, that's the intestines there, the bladder is there in front, and you can see a blue dye coming through testing the fallopian tube, and that's a nice clean pelvis. I need to rush because I think my time is running out, so I'll rush a little bit. That's a typical example of endometriosis. You can see these red spots. These are the spots that bleed every month, and we call it the red flare spots of endometriosis. That's an early stage endometriosis. Then you get this type of endometriosis. We call it the pepper brown spots. And you can see this is the area just behind the uterus. This is the uterus. This is called the uterosacral ligament. That's the rectum there. And this is also endometriosis. Okay, and these typically also bleed every month and gets inflamed every month. This is a nice example of what happens as the months go by. You start getting some fibrosis and adhesion formation, and that's how the damage starts happening. And then as it gets more and more severe, this is now a more moderate form of endometriosis, a lot more adhesion formation, the ovaries getting stuck to the uterus. And as the disease progresses further and further, that's what happens. That's more thicker adhesions. You get disturbance of the normal anatomy, you get thickening of the fallopian tube, and you get damage to the fallopian tube and the ovary. And this is also a very common type of finding where you find all these adhesions, distortion of the anatomy, it's stuck into the intestines, and there's these cyst formations. And if we see that we open up these cysts, you often find a very fine liquid coming out. We call it a chocolate cyst or an endometrioma, and that's usually now getting much more severe. And you can see this is probably one of the most severe forms, a very severe form, total distortion of anatomy, kissing ovaries. We call it kissing ovaries because they get stuck to each other. You can't see the back of the uterus. There's destruction of ovarian tissue and fallopian tubes. So these are the different stages of endometriosis. I'm not going to go through it, just simply to say that we define it in either stage 1, 2, 3, or 4. There's a whole point system that we use, and the more severe the stage, usually the more painful it is and the more difficulty in trying to treat those type of patients. So let's talk a little bit about infertility. It's a known fact that up to 50% of women with endometriosis will have difficulty in falling pregnant. Okay? It's important to understand that everybody with endometriosis won't have problems. As I said, 50%. So 50% of patients with endometriosis will be able to conceive. But it's the other 50% that have it that will have some type of problems in trying to achieve fertility. And there's several ways how infertility is caused by endometriosis. The one obvious way is the one I showed you before, the severe form of endometriosis, destruction of the anatomy, and you can see patients like this, there's no way that this egg will be able to get into the fallopian tube, and that's how they'll have difficulty in falling pregnant. This is a normal pelvis, this is mild endometriosis. But even in mild endometriosis, where the fallopian tubes are totally normal, the ovary is normal, people will have difficulty, and the reason for that is multifocal. It affects, Professor Buick said, that there's an immunological problem. Yes, we found increase in natural killer cell activity in patients with endometriosis. It affects ovulation, it affects egg production, it affects transport of the gamete, it affects implantation, and it also can cause miscarriages. So there's different mechanisms how it affects fertility. So, how can we treat patients with infertility? It's important to know that you have to look at lots of different parameters. The severity of the symptoms, the type of symptoms, the age of the patient, the desire to fall pregnant now or later on, the length of infertility, and how to cope with all the different side effects. So these all need to come about into discussing the different treatment options. However, just briefly, observation can be done. In other words, in a very mild form of endometriosis, you'll find that you can wait long enough. People will fall pregnant if there's no other problems. If the sperms are good, the fallopian tubes are good, they may still fall pregnant. But some people will require either hormonal treatment and surgery. So as I've mentioned, that we have to look at the patient holistically. There's no specific treatment. One size does not fit all, and we should try and individualize treatment. This is a whole algorithm of what we need to look out for. Of course, we have to do the basics, the examination first, look for any sperm problems, male factor infertility, look at the hormones, look at patency of the fallopian tubes, then do a laparoscope, treat it at the same time, and then, depending on that, we'll look at what's important, age and ovarian reserve. That's the two critical important factors, age of the patient and ovarian reserve. If you're over 35 or if you have a limited ovarian reserve by testing your anti-Mullerian hormone, one has to be more active in managing the fertility. If you're under 35, you have a good AMH, you can be more conservative, because it's a known fact that just doing laparoscopic surgery for endometriosis, you double the chances of natural conception. So we can see here from this graph, that's just doing a simple laparoscope without treating, that's doing a laparoscope with treatment, you're doubling your chances for natural conception. However, eventually, unfortunately, despite waiting long enough, you may require assisted techniques, and often many patients would then eventually require either intrauterine insemination or in vitro fertilization. So in conclusion, endometriosis, a disease characterized by ectopic endometrial implants throughout the pelvis, negatively impacts fertility. Although endometriosis impairs reproduction, it does not usually completely prevent pregnancy. A combination of surgery, ovulation induction with intrauterine insemination, and assisted reproductive techniques such as IVF can help many couples achieve their dream to be able to achieve a pregnancy. Thank you very much.